Good morning, everyone. My name's Dr. Damien Key. I'm a medical oncologist at the Peter MacCallum Cancer Centre in the Austin Hospital. And on behalf of the organising committee, I would like to welcome you to the third Australian Ocular Melanoma Alliance Summit. I'd like to open the meeting by acknowledging the traditional owners of the land of the virtual host, the Peter MacCallum Cancer Centre, the Wurundjeri people of the Kulin Nations, and pay my respects to their elders past and present. Anthony.
Yes, thank you very much, Damien. As the current co-chair of AOMA with Dr. Leanne Lim, who is the ophthalmology co-lead, I just wanted to welcome you all to the meeting, and also thanks, make a formal vote of thanks to Damien, Claire and the MASK team who have done such incredible work, and the team at ASN Events in terms of getting this event up and running. AOMA is obviously very grateful for everyone's input and assistance, not to mention our sponsors who have provided the real impetus to get this event going, being now a global event and of importance to both ocular melanoma oncologists, radiation oncologists, allied health professionals, as well as importantly patients. So we're all very grateful to them for assisting us. AOMA was started a number of years ago as a spin-off from MASK Clinical Trials to provide both medical, paramedical and consumer-based input into the landscape of ocular melanoma in Australia. It is obviously an area of significant unmet need, and AOMA is very proud to be an organisation that prides itself on the multidisciplinary integration of both the professionals treating and assisting with ocular melanoma, as well as the patients who we look after on a day-to-day basis.
Yeah. So we were very much looking forward to meeting you all in person, but as those of you who have been keeping track of our social media, we've had to adapt as the time has gone on, from May being an entirely in-person event to becoming a hybrid event in June, and more recently, unfortunately, going to a fully virtual event. So we thank the MASK team and ASN for keeping up with these changes, and we thank you all who are attending now for bearing with us. To keep the conference as interactive as possible, we would very much like to encourage you to submit questions and answers into the Q&A tab, and we will have the panelists and the conference chairs help or answer your questions during each of the allotted sessions.
Okay, so we'll now get started on the first part of the program, and it gives me great pleasure to launch with the first plenary from Dr. Paul Nathan. I'll do his introduction, then I'll leave Damien to introduce the consumer panel after the end of Paul's talk. So Paul is really a giant in the field of ocular melanoma, but both in the European and global sphere. He's a consultant medical oncologist at the Mount Vernon Cancer Centre, Northwood, and a clinical associate professor at University College London. His specialist interests include both the treatment of melanoma and renal cell carcinoma, originally trained at Cambridge and had some involvement in the pharmaceutical industry. He is a trustee of the Melanoma Focus and the National, which is a national UK melanoma charity, and has been pivotal in crafting guidelines for the management of ocular and cutaneous melanoma in the UK area. He's the EOTC Melanoma Systemic Treatment Lead and chairs the UK Guideline Group for uveal melanoma. So without any further ado, I'll hand over for Paul's pre-recorded talk.
Hello, and I'd very much like to thank Damien and Anthony for the opportunity to talk to you. I'm really sorry I can't join you for the panel discussion and questions. I'm be on holiday walking in northern Spain as long as I can get through a UK airport today. So I'll be talking about systemic treatment choices for uveal melanoma. These are my conflicts of interest. And I'll focus on Tebentafusp, checkpoint inhibition, and then some selected emerging agents. So back to basics, first of all, with Tebentafusp. And the point about T-cell receptor-based treatments is that they can see a far larger proportion of the cell proteome than therapies which target the cell surface. So antibodies, antibody-directed therapies, bispecifics, ADCs, antibody-directed CAR T cells, they all recognize proteins on the surface of the cell, and they probably represent perhaps 10% of the proteome. Whereas T-cell receptor-based treatments recognize peptides that have been sampled from a far larger number of proteins intracellularly, and those peptides are obviously presented in the context of HLA on the surface of the cell, and therefore one potentially is sampling a far greater library of neoantigens, tumor-specific neoantigens, or tumor-specific antigens, using T-cell receptors against peptides derived from intracellular targets. So this is Tebentafusp, and it's an affinity-enhanced T-cell receptor for a peptide derived from the GP100 protein. GP100's widely expressed in melanoma cells, and particularly highly expressed in uveal melanoma cells. So this is the T-cell receptor part of the drug binding to a GP100 peptide in the context of HLA. So this is an HLA restricted therapy, and patients have to have the appropriate HLA haplotype. At the other end of the agent, there are Fv fragments directed against anti-CD3. So CD3 is a widely expressed T-cell antigen, and it also activates T cells when bound. And therefore one can see that this drug effectively takes T cells in the tumor microenvironment, activates them and redirects them to GP100 expressing melanocytes. So it doesn't matter what the T cell receptor specificity is of the T cells in the tumor microenvironment, they are directed in a specific way to the tumor cells by Tebentafusp. So a little bit about the development of this drug, because there are some issues that pertain to its use in clinic. This was the phase 1 study that also included a dose expansion cohort. We started with an intrapatient dose escalation with 20 micrograms on week 1, 30 on week 2, and then explored a number of final doses and identified 68 micrograms as the recommended phase 2 dose going forward. This intrapatient dose escalation schedule was identified as just reducing the cytokine release syndrome when patients are first exposed to the drug. And you can see in this initial group of patients, there was evidence of efficacy with some modest tumor shrinkage, but more profound tumor stabilization in a number of patients. You can see this goes out to 2 years or so on the spider plot. In terms of the AE profile, the drug does induce a cytokine release syndrome that does sometimes need active monitoring. Well, it always needs active monitoring and active management. It's nothing like a CAR T cell CRS. Patients can become hypotensive and need fluid support and often need antihistamines and topical treatments for rash. And you can see here on week 1, week 2, week 3, the type of side effects and the grade. The interesting thing about this profile is that it falls off dramatically, and once you've gone beyond week 4 or so of treatment, the agent becomes very benign to use. The SPC for the drug, I understand, does not any longer demand overnight stays, In our practice, we do keep patients overnight for the first 3 to 4 weeks of treatment. And they certainly require active monitoring for significant time after taking their drug for those first good number of hours. There were a few paired biopsies on this study, and we could see a brisk infiltrate of T cells, including both CD4 and CD8 T cells. So there's an expansion cohort of that study. 127 patients were recruited, and these patients all had to have at least one line of previous treatment. Nearly 60% of patients had a raised LDH. Over half of patients had liver disease greater than 3 centimeters in diameter. 2/3 of patients had one line of treatment, 1/3 of patients had 2 lines of treatment, and many of these patients had previous checkpoint inhibition. You could see the AE profile was that which I've just described to you. And this is the overall survival curve. Now, this is a single-arm study, so don't be put off by the fact that there are 2 lines on here. The performance of the patients on this study is this dark line here. And the 1-year overall survival was 62%, with a median survival of 16.8 months. And the comparative line here is from the Rantalis study, which was a meta-analysis of second-line and further treatments. And you can see that against these historical controls, patients receiving Tebentafusp on this study appear to have significant benefit. And that led to the phase 3 study. It was a head-to-head study against standard of care because there was little in the way of a standard for metastatic uveal melanoma because of the lack of progress over many years. Investigators were given a choice. They could treat with either dacarbazine, single agent, ipilimumab single agent, or pembrolizumab single agent. And in fact, 82% of the patients randomized to investigators' choice had pembrolizumab. There was no combination ipi-nivo allowed on investigator choice, and I'll refer to that in a little while. So patients obviously had to be HLA-A201 positive, have no previous systemic treatment, and this was the randomization. In terms of co-primary endpoints, overall survival randomized to patients of Tebentafusp compared to investigators' choice. There was a secondary co-primary endpoint, rather not a secondary endpoint, a co-primary endpoint of performance of patients experiencing rash in the first week of treatment. And that was because in the phase 1/2 study, we thought we saw an association between rash and efficacy, although in fact that was not the case in this phase 3 study on a multivariate analysis. So this is the patient population on this phase 3 study. A third of patients had elevated LDH. Half of patients had small volume disease, less than 3 centimeters. Half of patients had hepatic-only disease, and 44% of patients had both hepatic and extrahepatic. So it's only single-figure percentages of patients who had only extrahepatic disease. And this is the overall survival curve. The hazard ratio for overall survival was 0.51 in favor of Tebentafusp. That translated to a 1-year overall survival rate of 73% compared to investigators' choice of 58%, with a median uplift from 16 months to 21.7 months, so nearly 6 months in terms of median uplift. This is the pre-planned subset analysis, and you can see benefit in all in all groups of patients. However, there are some trends here that may be helpful in selecting patients for treatment. And if you look at the size of the metastatic lesions, you can see a trend towards a greater benefit from patients with small volume disease rather than large volume disease. And so it is something to be aware of when thinking about selecting patients for treatment. and we prefer to treat patients with small volume disease. This is a PFS Kaplan-Meier curve, and you can see there is a separation and a statistically significant difference between these curves, but the hazard ratio was 0.73, which is inferior to the overall survival analysis. In other words, radiologically, one seems to have less benefit than survival benefit. So that's an interesting observation. Normally, or frequently in oncology studies, one sees a greater effect on PFS than one does see on OS. Now, when one looks at patients who had progressive disease as the best response, in other words, there was no evidence of stability, no evidence of response. These are patients whose cancers just carried on growing. Patients in that group who were randomized to Tebentafusp did significantly better than patients randomized to investigator choice, with a hazard ratio for overall survival of 0.4. Now, these patients were allowed some post-progression treatment. So the protocol on the study allowed patients to have treatment beyond progression on their first scan, but if they carried on progressing on their second planned scan, treatment was stopped. So this is not open-ended post-progression treatment that patients had. They had limited post-progression treatment, but that still translated into long-term benefit from patients, for patients who had been exposed to Tebentafusp. And the implication from that observation is that the drug may be looks to be affecting the tumor microenvironment in a way that changes tumor kinetics in a longer term period, even once treatment has been stopped. The AE profile was similar to that which I've shown you previously, and I won't go through that further. The one thing I would say is that only 2% of patients discontinued Tebentafusp because of AEs. And so, although the first 3 weeks or so does need active management for these patients because of the cytokine release syndrome, actually the vast majority of patients can get through that and carry on with their treatment. Now, Alex Shistari presented some ctDNA data from the phase 1/2 study, the 102 study. And what he showed was that there was a large group of patients who had a reduction in ctDNA. About 70% of patients had a reduction in circulating ctDNA looked at by week 9 of treatment. And so one's seeing much greater effect using ctDNA as a surrogate biomarker than one is radiologically. Now, that would be a bland observation if it weren't for the fact that there was a tight association between reduction in ctDNA and overall survival hazard ratio. And so the lower the ctDNA reduction, the greater the benefit, the smaller the hazard ratio for overall survival. And the implication of this is that there's a far more significant correlation between survival and reduction in ctDNA than there is between survival and radiological change on the MRI and CT scans that we used on the study. And therefore, it may be for this type of treatment in this disease, we need to think of non-imaging markers of response. So Tebentafusp is the first soluble T-cell receptor fusion protein with a survival advantage. And it's the first systemic agent with a proven survival advantage in metastatic uveal melanoma, but there are limitations. It's obviously HLA-A2 restricted. That means about 50% of Europeans. I'm not sure what the rates are in Australia. I've mentioned that RECIST underestimates survival benefit. Significant clinical remains. This is a palliative treatment with a median improvement in survival of 6 months. There's obviously questions about the adjuvant setting, but it does pave the way for other T-cell receptor therapeutics in uveal melanoma. Now, I want to mention a little bit about combination ipilimumab and nivolumab. There were 2 studies reported last year in JCO, one from the Spanish group and the other from the US group, both single-arm studies in patients receiving combination ipilimumab and nivolumab. This is the Spanish group, and one can see here that there was a benefit predominantly in patients who had extrahepatic disease. I'll come back to that in a second. The median overall survival was 12.7 months, and 40%. Most of these patients had liver disease. Rather, 80% of these patients had liver disease and small volume liver disease. This is the US study from Sapna Patel, and again, there are patients who seem to have some benefit. The 1-year overall survival was 56%. Remember, the 1-year overall survival on the Tebentafusp study for the investigator choice arm was 58%. So Joseph Poulatz and Sapna Patel did an analysis of their combined cohorts of patients on these studies and matched them to 170 patients from the PUMA analysis. So that's Anthony Joshua's analysis of patients receiving historical treatment first line, and they matched these patients, these 170 patients, for age, sex, ECOG status, LDH, and M status. And the only group who appeared to have benefit from ipi/nivo against these historical controls were the patients with extrahepatic disease only, with a hazard ratio of 0.28. Patients who had liver disease or both liver and extrahepatic disease appeared not to have any benefit. And most of you will be aware that it's a small minority of patients with metastatic uveal melanoma who have extrahepatic disease only. So I mentioned that, with the combination ipi/nivo studies, the 1-year overall survival, 56% on the American study, 52% on the Spanish study, and that compares with 58% 1-year overall survival for the control arm on the Tebentafusp study, most of whom who had pembrolizumab. So I would say that certainly in terms of 1-year landmark survival, there's no evidence that ipi/nivo has any benefit over single agent checkpoint inhibition. The question is whether there's a cohort who have more durable benefit from ipi/nivo, and there may well be, but it's likely that that cohort is limited to those who have extrahepatic disease. And the question about this combination, is it justifiable for those with hepatic disease in terms of toxicity? As you know, ipi/nivo, a melanoma dose, is pretty toxic. Now, there are other checkpoint inhibitor targets, and most of you will be aware that LAG-3 inhibitors are becoming a standard of care for metastatic cutaneous melanoma. The combination of relatlimab with nivolumab is licensed now for melanoma in the US. And there's elegant work from Bill Harbour's laboratory showing high levels of LAG-3 expression in cell populations in uveal melanoma. And so the relatlimab-nivolumab combination is being investigated in study at the moment, and we'll see whether or not there's any greater activity of this combination uveal melanoma. One of the attractions also is in the toxicity profile of this combination, which is improved over ipi/nivo. And then finally, I'd just like to mention a few things that are under investigation. Darovasertib is a PKC inhibitor, and it now has orphan drug designation for uveal melanoma. It's been looked at in a couple of different combinations, both with binimetinib, which is a MEK inhibitor, and crizotinib, which is a MET inhibitor, although it's also an ALK inhibitor. And this combination of PKC inhibition and MET inhibition appears to have some lethality for GNAQ, GNA11 driven cells. And there's been this early report on the IDEA company website. IDEA have the darovasertib, and they've paired up with Pfizer with crizotinib. And the earlier report was that there was an overall response rate of 30%. And that's interesting in uveal melanoma. They refer to a manageable side effect profile. And so obviously we need to see durability of response and more data about toxicity for this combination, which is in expanded studies and of significant interest. The second study, the second agent that's in development is an antibody drug conjugate from Novartis called DYP688. It's in a phase 1/2 study at the moment, and it's based upon the suggestion from about a decade ago that a protein involved in melanosomes may provide a target for an antibody drug conjugate therapy in melanoma. And the thing about ADCs is that the only reason to use an ADC is if you can make the what's potentially a quite toxic drug tumor selective. So that's the first thing. The second thing is there's always a challenge with ADCs about how much penetration within the tumor that the antibody can get, and whether or not there's an adequate bystander effect for the drug, and whether or not the toxic moiety is released to levels that cause systemic toxicity. So those are all open questions. It's an interesting agent, and we obviously need to see the trial data. And then finally, I just thought I'd mention IOA244, which is a PI3 kinase delta inhibitor, which is really this poster was presented at ASCO just gone. This is a very well tolerated agent. There's not a direct effect on MAP kinase if it's it's PI3 kinase specific, and it seems to have an effect on T regulatory cells, with some data showing reductions both in the periphery and in tumors. There's a study ongoing at the moment with this, with some recruitment to uveal melanoma patients. So final slide. For the first time, we've had improved standard of care in metastatic uveal melanoma with a systemic agent, and it does feel as if it's a breakthrough moment. Obviously, clinical need remains, not just for those patients who are unlucky enough not to have HLA-A201 as their MHC class 1, but we need improved metastatic control. And there's obvious questions about whether or not this drug is active in the adjuvant setting. I think one of the things that happens when you've got some progress is it does lead to increasing activity. Tebentafusp has shown that you can develop a drug and get a rapid license in uveal melanoma, and that's attractive for companies. And there are a number now of agents of significant interest that are ongoing in clinical trial activity. I know the Australian teams are very involved in many of them. So with that, I'd like to thank you for listening, and I hope you have a super meeting, and very much hope that in years to come I'll be able to join you. Thank you. Bye-bye.
Well, thank you, Paul, albeit virtually. I see that there's one question on the Q&A from Dr. Shackleton. Is there a subgroup analysis of extrahepatic only disease in patients from the phase 3 study? I think the answer to that question is that I'm not aware that there is. On the forest plot in the supplementary appendix in the New England Journal paper, just talks about the largest metastatic lesion. Someone I'm sure has that data. but I'm not aware that that's the case. I think generally speaking, though, patients with extrahepatic disease do better as a whole. But interesting observation. I don't know if there's any other questions, if people want to add them to the Q&A, but obviously a very exciting time for uveal melanoma, and I guess relevant to say that AOMA is undertaking a world first study in giving darovasertib, which is the PKC inhibitor in that study, in patients prior to enucleation to understand how the drug works. And we have, I think, aspirations of larger studies in other settings that are currently under evaluation. What Mark's other question is, what is the status of disease monitoring during TEBI treatment in Australia? How do we know who is responding? Damien, do you want to, I don't want to dominate, do you want to chip in?
Yeah, so yeah, thanks for the question, Mark. I think it's one of the more complicated aspects for treating patients with Tebentafusp is working out when they may potentially not be benefiting from further treatment. And given that they don't tend to have as easy or as objective a measure as a radiological response that we typically see with other anti-cancer treatments, sometimes it is a constellation of both clinical benefit, biochemical improvements. So quite often I'll see patients have improvements in their liver function tests despite having radiological progression or mixed responses. And then it is a matter of working out whether any of the lesions that might be getting bigger are likely to cause problems, and potentially treating those with local treatments as well, whether it be radiotherapy or others. So it's still very complicated, and I think it is a matter of a whole constellation of looking at the patient as a whole. Anthony, have you got anything to add to that?
Yeah, no, I don't. I think that you do get a feel for the patients in terms of their progression, their systemic, whether they're systemically unwell and having symptoms. And certainly now that the clinical trial is over, there's more flexibility, as you said, to involve local therapies in the managed access TEBI managed access program that allow some flexibility for locally directed therapies involving our radiation oncology colleagues. And there's a question there from Rachel Roberts-Thompson about monitoring. So certainly that's a very astute question, and certainly that is the case, that in the major centres that undertake monitoring for surveillance, we, at least I can speak for Sydney, we adhere more or less to the NCCN guidelines, which outline a very strict surveillance schedule. And the reason that we're so adamant about it is exactly what Dr. Nathan said, is that it's better to treat low volume metastatic disease than high volume metastatic disease. And that, of course, is now added by the fact that in Australia, the MRIs of the liver are now on the MBS. So in the past, that is probably the best test for monitoring, and they're now free. Obviously, in the past, we were mixing and matching various imaging modalities, but it's now easier to do. So that's a very good question, and the answer is that yes, we are being, certainly in the larger centres, being very proactive about that.
Yeah, I think, Rachel, we're in a situation where we were with cutaneous melanomas roughly 10 years ago, prior to the introduction of a treatment that improved overall survival or an active clinical trial program. There was very little justification for doing early surveillance, but now that we have an active treatment and we have much more active clinical trials, a lot of Victoria as well as New South Wales have adopted a more structured surveillance program. And
then Mark's question about a national research initiative. So yeah, I think the beginnings of that are underway, and certainly with TEBI in Sydney, we've biobanked all our patients who are having TEBI treatment, and Damien and I have had discussions about doing an Australian experience paper with Tebi into next year, combining our patients. So, you know, we've got, obviously, we'll hear from Ellen Gray and Erin later in the day about their excellent work about monitoring. So that may lend itself to that.
Okay, we better continue with the program. So I think Anthony has mentioned that we now have a Tebi Access program, and the Tebi Access program has been running for just over 12 months now. And it is with great pleasure that I can introduce our consumer panel, which is Jessica Rowe and Neil. And Jessica has the, I guess, is notable for being the very first patient I put on to the Tebentafusp Access program, and we just celebrated her 12-month anniversary a few weeks ago. And Neil has the more unfortunate situation of being one of the most recent patients I put onto the Tebentafusp program. And when I asked him to be part of this consumer panel, I believe it was in his hospital room after he just had a miserable night during one of the acute induction phases. So hopefully they have an interesting and mixed experience that they can share with us. So if we can get started with their talk.
Good morning, medical professionals, fellow cancer patients and guests, and thank you for your time today.
I'd like to introduce myself. I'm Jessica Rowe, 38 years old, and I was first diagnosed with ocular melanoma in 2009 while I was living in Greece. It actually took a few goes to find the diagnosis. They thought it was a detached retina, but after a referral to the hospital in Athens, they found the melanoma. What inspired me or triggered me to get my eye checked out was there was a flashing in my right eye. For around a couple of weeks, I felt really well, and I honestly thought it was just too much sun, too much fun, and not wearing the right sunglasses.
Hi, my name is Neil Vincent. I'm 65 years of age, married, 3 awesome sons. I was first diagnosed in February of 21, where I experienced slightly blurred vision and watering to my left eye that prompted a visit to my local GP and optometrist. They both picked up that something was not quite right within my left eye. They actually thought I had a detached retina, referring me to specialist Dr. O'Day. Still February 21, on my first visit with Dr. O'Day, he diagnosed me with a choroidal melanoma to my left eye. Unfortunately, the melanoma was large and too big to be treated. Moving forward, we were now discussing eye inoculation. It had to be removed.
So before I begin about how I got to Tebentafusp, I'd like to share my journey of how I got here. So on the 30th of July 2009, I was diagnosed, which is exactly 13 years to the day I was diagnosed. So it's kind of a nice coincidence, the summit's being hosted on 30th of July today. I flew back to Melbourne and I had the plaque treatment. The plaque treatment was successful. And then after that, every 6 months, I was having routine ultrasounds. In 2018, during a routine ultrasound, I was feeling very well. So it was very unexpected and quite shocking to find out there were 2 liver mets. I decided to go to a surgeon, and the surgeon said that he could perform a liver resection. I was very grateful. The liver resection, as brutal as it was very successful, and both the melanomas were removed from my body. To be super safe, the oncologist decided to put me on 6 months of Keytruda. Although they couldn't detect any melanoma or cancer cells in my body, they thought it was a good idea to sort of flush my body and kill anything that was hiding in my bloodstream.
It's now March 1921. Inoculation surgery was completed and my left eye was removed. Moved on to 15th of June 21. And my first visit was with Patrick and Camille from Loyer Artificial Eyes. Awesome experience with 2 very professional and skilled people in Patrick and Camille. To experience the process, to watch a prosthetic eye be handmade hand painted to a perfect match and fit to the remaining eye was incredible. Could not recommend them both more highly, and thank you very, very much. July 21, I had a follow-up visit with Dr. O'Day for further prosthetic eye examination and movement, all clear with a great outcome. Still in July of 21, I had 3 minor strokes. These strokes put me in hospital and rehabilitation for 4 weeks. After release, I had ongoing rehab for quite some time. Moving into October of 21, I had my initial consultation with Dr. Key, where MRI scans, blood tests and monitoring began for any further signs of cancer. I'd moved into March of 22. I had a further MRI scan. The search had started in earnest and followed up with a visit to Dr. Key to discuss the results and findings. It was confirmed I had 4 liver lesions of various sizes, and shortly after followed by a liver biopsy to be completed.
So go back to March last year in 2021, I had another routine scan, which I regularly do, especially after the resection. And I was feeling again really, really well, nothing I was alarmed about. And then they picked up on an ultrasound that there was something there. I had an MRI and a PET scan, and it was then confirmed there were 4 new liver mets. I decided to swap medical teams and I moved to Peter Mac. I was introduced to the amazing team, Dr. Damien Key and all these group of amazing doctors and nurses, and they told me about the drug called Tebentafusp. But before I could be put on the drug Tebentafusp, they had to determine if I was HLA positive, which is a gene match for the drug. Had the blood test, and that took around 3 weeks for the results to come in. That was a very, very anxious 3 weeks. And I honestly thought I probably wouldn't be a match. So I didn't want to put my hopes that I'd be, be given Tebentafusp. Fortunately, I was really lucky and blessed when Damien said I was a match and I would be able to have the drug Tebentafusp. However, the drug wasn't set up in Victoria, so I had to wait a couple of months for it to be set up at Peter Mac. And when it was ready to go, things moved very, very quickly. I got a call from the amazing nurse, Donna Milne, and within 48 hours, I was at Peter Mac. And because I was the first patient in Victoria out of a medical trial to be given the drug, I do like to call myself proudly patient number 1.
As previously mentioned, my scan results had shown 4 lesions within my liver, not the results that we were hoping or looking for at all. During my follow-up with Dr. Key, we discussed a few treatment options. Blood tests had already been completed and confirmed that I was suitable for Tebentafusp. It was all systems go. April 6th, my journey began with Tebentafusp, and my first weekly infusion was completed, and I am now up to infusion number 17.
Now I would like to get to the fun stuff, which is side effects. So before I started the drug, Damien did tell me that the first few weeks are pretty rough, but I thought after a liver resection, I could handle anything. This is going to be a walk in the park. So I had the infusion, which is only 15 minutes, so nice and quick. And then I got moved to a private room and nothing happened for the first 6 to 8 hours. And I honestly thought I dodged a bullet. I text my mum, my boyfriend saying, this is easy, I can do this. And then at around 8 p.m. that night, I started feeling very, very hot on my face and a bit prickly and warm. My underarms got very, very itchy and my neck started getting really itchy. So I went to the bathroom and looked in the mirror, and yes, the side effects had kicked in. You can see on both my face, neck and chest how red raw I was. The white on my face is where I had no pigment because the Keytruda had killed some of that. My lips were peeling and the rash went from my head all the way down to my legs. This is the next morning, still very, very red, very sore and very dry. In this image, you can see again, the skin starting to peel and blister on my chin, and on the right is all the way down my legs. So it may not look too intense, but the sensation felt like someone had put me in a hot ant's nest and the ants were spitting fire on me.
My first infusion required overnight stays to monitor side effects. For the first 6 hours after the infusion, I felt fine with not a whole lot going on during this period. Shortly after the 6-hour time period, I began to feel extremely cold and feverish, although my body temperature was quite stable. I started to shake violently with the need for thermo blankets to control the shaking and cold sensations. Fever-like symptoms and shakes lasted for about an hour and a half. The shakes had stopped and I felt quite warm. This lasted about an hour and I now began to feel very warm, to the point I was running a temperature of around 38.9. During this time, I'd broken out into a rash behind the back of my neck, forearms and hands. My whole body felt like it was on fire and incredibly itchy. My skin was extremely sensitive, to the point it was quite painful to the touch. This lasted for quite a few hours, where I had ice packs on the back of my neck and forehead to ease the rash pain and lower my body temperature. Very uncomfortable, with very little sleep during this time. The following morning, my temperature had lowered, although still had rash with itching sensation over my entire body. The next day was a washout. Slept and treated pain and rash with Panadol and creams. I was also extremely dehydrated and found water with added hydrolytes helped a lot. Later same day, early evening, started with the fever sensation again, where I had the shakes and felt very cold for approximately an hour. Had taken further Panadol and antihistamine tablets that helped to ease the itching sensation for a better sleep.
And then ongoing side effects. So I've had over 60 infusions now, and overall, I don't actually feel many side effects from the Tebentafusp. I do have fatigue, which I manage with either a nap, but I have, the biggest thing I've noticed long-term is vitiligo. So I used to be very, very bronzed and very, very olive, not anymore. The drug has killed the melanin in my body, but I like to think that's a good thing because the drug's working and it's doing something. It's also dyed my hair, or taken all the pigment out of my hair white. So I have white lashes, white brows and white hair, but you wouldn't know because I'm vain enough, and I tint my lashes and brows weekly, and I get blonde and all sorts of colors put in my hair to bring it back to where it was a year ago.
The side effects continued to the point on my visit for my third infusion. The decision was made to rest for a week, as my hands and fingers were extremely swollen and blistered. The concern was that my hands broke open into blisters and sores. They may need to stop all future infusions for quite some time for them to heal. Thankfully, the week rest worked and I could continue with weekly infusions where I stayed overnight. The side effects were still there and peaking. My entire body skin was very dry, peeling and sensitive to the touch, extremely dehydrated and fatigued by the end of the day. My face completely peeled, including eyelids, and my lips had cracked open. The bottom of my left foot completely peeled several layers of skin. My hands and fingers were swollen, blistered and peeling. My body would experience pins and needles sensations randomly.
Sorry, so currently I'd like to share where I am with my drug, Tebentafusp, and my disease. So 2 liver mets have disappeared, which is wonderful and very unexpected, because the drug's designed to sort of stabilize or shrink, not to get rid of the disease. I have 1 liver met that I've called Larry because he's big and he's badass, and he's on my liver on the left lobe. I have a lung met that's stable, and I've also just completed 5 rounds of radiotherapy. The radiotherapy is not curative. It's purely to shrink the tumor, or Larry, because he was quite large and he was putting a lot of pressure on my stomach and abdomen, which meant I had to stop work. But besides that, I'm feeling pretty good. I get fatigued, which I can manage. I have stomach discomfort that I can also, Panadol seems to help, and a lot of rest and just look after myself. I've also got a great appetite, which helps with energy levels.
My current update is I have 4 liver mets lesions still present. 2 liver mets lesions have grown in size. I'm continuing with Tebentafusp treatment for now. We are reviewing and maybe a transition into other treatment options that we've yet to be decided. There's still quite a lot of work to be done before we move away from Tebentafusp. I'm feeling well with mild abdomen discomfort. I have a good appetite. My weight is still stable. My bloods are stable. I have mild fatigue towards the end of the day, which I just treat with just rest and sleep. Thank you.
So Neil and I would like to thank and send lots of love to a lot of people. There's a big army behind us that help us look after us medically, physically, emotionally. And they are Dr. Damien Key, Dr. Donna Milne, Dr. Margaret Chua, Dr. Rod O'Day, Alethea Lobo, the whole Peter Mac oncology team, from the nurses to the admin to the check-in QR code guys downstairs, Patrick and Camilla Lawyer at Ocularist Prosthetic Eye, Dr. William Campbell and Mary Harvey. Thank you so much.
Yeah, thank you so much, Jess and Neil, for sharing your experience. Very warts and all, and I think really valuable for a lot of the people on the people attending the meeting today. We've had the Tebentafusp Access Program open at the 3 of the trial centres, and more recently, the Tebentafusp program is now opening up at sites that haven't previously had any experience with Tebentafusp. And I know that I get a lot of emails daily about what to expect and how to actually manage people. So I think that your very honest report about your initial experiences with Tebentafusp will be enlightening and valuable to them. So thank you so much.
Is there any other questions? We seem to be running just a smidgen early, so we've got some time for questions. If anyone wants to ask any to Jess and Neil. No? All right. So thank you very much. Oh no, here's a question. So Tim is asking, what would Jess and Neil say to another person considering going on this treatment?
I would say if you are an HLA match, definitely consider it. For me personally, the first 3 infusions were quite rough, but I was quite textbook in the sense that after the first 3 infusions, from infusion number 4, it was actually quite easy for me. I didn't have to stay in hospital overnight. The infusion's only 15 minutes, so I could be in and out of the hospital with an hour and a half. The side effects wore off, so you could kind of go about your day after. So I managed to work throughout my infusions. I've only recently just have a break while I'm doing radiation. But overall, the weekly infusion just slotted into my lifestyle. I don't even think about it. It's like going to the office. So if you are a match and you can do it, I highly, highly recommend you do it. And if you think the first few weeks are rough, stick with it. It does ease up and it does get better.
There's another question which is in the panelist chat, which is, has anyone else reported vitiligo? And I guess I'll inform you that I guess Jess had a little patch of vitiligo prior to starting Tebentafusp. So she was unusual in that she had been treated previously with pembrolizumab in an adjuvant context, but many of the other patients prior to having access to Tebentafusp might have been exposed to various immune checkpoint inhibitors. In fact, one of our other early patients had a very similar experience to Jess. Previous treatment with an immune checkpoint inhibitor, a little bit of vitiligo, which got worse with Tebentafusp treatment. I'm not sure whether others, Anthony, have you seen any vitiligo purely from Tebentafusp?
I did. In one of the patients who was on the pivotal trial, but not as commonly as I think with the other checkpoint inhibitors, where it's but it certainly it does bode well in terms of prognosis, as one of the chat people have said, in terms of immune activation, which makes sense. Mark's also asking a question before we have to move to Jonas's talk about how can professionals better support patients on TEBI. So I think it's my perspective on that is education and support. So I think, you know, I think the oncologists that administer the TEBI are still learning, yes, that's my perspective, but we're learning with the patients. So Jess and Neil, what are your perspectives about how to manage?
I don't know if Neil wants to answer this one. I answered the last one.
Look, I feel the information that we got, or that I personally got from Dr. Key before I started, was very informative. It's one of those things you can, I guess, be told it, look at it, read it, but until you experience it, you really don't know what you're in for. I stayed in for 4 sessions due to the side effects, but the more information you can get, the better, I guess, the better prepared you are, but nothing really prepares you 100% for what you go through. You get tipped upside down, inside out. But when you come out of the other end, was that a bad nightmare, or did I just live all that? And as Jess has already mentioned, if you are eligible for this and you can get through the first lot of infusions, stick with it. Just stick with it, because it does get better. And as for the overall management with the oncologist team, especially what I've experienced at Peter Mac, phenomenal, just awesome people that are only too happy to explain anything. Any question is on the table. There is no filter with this. It's really helps you get through it.
Anything you want to add, Jess? And then we better move on with the session.
No, I completely agree with Neil. Everyone there gave me so much support, including Dr. Key. Any questions are answered. I can email a nurse whenever I want, or email the team. People get back to me quickly. If I need to go in and chat, I can call up and make an appointment. I feel supported the whole way through. And when I moved to Peter Mac, I felt like I just handed the reins over, and it's almost like one less thing for me to worry about. And yeah, completely supported, and I couldn't ask for a better medical team.
I didn't pay them.